So welcome everybody. My name is Jackie Walumba and I'm the Vice Chair of the PPA, the Physiotherapy Pain Association, and welcome to our afternoon webinar on reflecting on digital consultations. Just a few bits on housekeeping. So microphones, as you've noticed, will be muted as you enter the meeting, and cameras also disabled on entry. If that's not happened, would you mind turning off your camera just to allow the speakers to have some prominence on your screen? And please use the chat function on my screen. It's on the right hand side throughout the webinar to ask questions. Members of the PPA will be screening that and bringing that to our Q&A session. There will be a time for the panel to answer some questions, and we're going to try and stick to time as much as possible, but there is some leeway on that. As I said, the webinar will be recorded and we will share that, as we did with the one last week, on our website. We're not providing CPD certificates for attendance in case you need that. And okay, so just to give you an idea of what we're going to go through this afternoon, we have 8 speakers and they're going to be speaking for 10 minutes each, hopefully. So just to give you a sense of how fast we will be going. I will introduce each speaker in turn as they come up, just in the interests of time. And whoops, you don't need to see that anymore. Okay. So are we ready? Just thinking of you, Louise, if we just, if you guys want to switch off your cameras, is that okay for our participants who aren't speakers? If you can turn off your camera. Or Dermot, is that something that you can do?
No, it's not something that I can do. I can only ask to start cameras, I'm afraid, but
All
it's
right.
okay, they're all switched off. Yeah.
So it's just, we've got Stephanie Stevens, if you could turn off your cameras, if at all possible. All right, well, we're going to get started. So it is my pleasure to introduce Louise Trewern, who's our patient advocate, and she's going to speak to us today about virtual consultations, this time again from a patient's perspective. And I will let her go straight ahead. Just a quick bit of housekeeping. If everyone else can see lots of other videos happening, if you go to speaker view, you should be able to focus on Louise's presentation only while other people work out how to switch off their cameras. All right, thank you very much. Off you go, Louise.
Thanks, Jackie. Good afternoon. My name's Louise Trewern and I'm a patient advocate, a passionate patient advocate. And I'll tell you a little bit briefly about my story. I live with fibromyalgia and arthritis, and for over 13 years I was on opioid medication for those conditions, which really were debilitating. And I didn't realize this, of course, until I came off. So I went into hospital and came off rapidly, the medication, and got my life back. And the way I did that was getting active and staying active. And just before COVID, I got struck with knee pain, totally out of the blue. I hadn't had an accident, hadn't done anything, but it quickly became a huge problem. So I wondered how I could address this. All the things that I'd learned through working with the clinicians that helped me, all the tricks and tips that I'd picked up didn't seem to be working for me. What else could I do? So I got in touch with physiotherapy and was lucky enough to be able to have a video conference with a physio, which I think was my saving grace through COVID, because he was able to give me some excellent advice on what to do and how to cope, and reminded me of the coping strategies that I had learned previously. I was able to see how I was walking and how it was affecting me, and gave me some tips. So I went away and followed his advice, and it worked really well. So that's the first thing to stress, was that the video consultation, although it's not ideal, it worked. He was able to see me and I was able to see him, and it was just easy, which is key, I think. And so we followed this with a follow-up call about a week and a half later, maybe, where I had made significant progress, but it hadn't gone. So again, he adjusted the advice he'd given me, the exercises he'd asked me to incorporate, ones he'd asked me to drop. And again, this was working really well. After a while, I noticed that it was getting better. And now I can report that at the end, you know, well, I say at the end, we're not at the end, but towards now in time, my knee is better, a lot better. It's not completely gone, but it is so much better. So for me, access to that digital consultation was excellent, and I worry about where I would be if it weren't available. So one of the messages I think I'd like to pass on here today is that it's different. Yes, it's a different way of working. It may not be ideal, but at the moment, I think it's the best we've got. And you know, you guys are all professionals. You know what you're telling us is sound. So the only thing I think is the worry here is that it's new, but it's new to everybody. And I think people are forgiving of that fact. So nobody's expecting it to be perfect, but the idea that we can access this service at all right now is just going to be brilliant for people that haven't been able to access any help through the whole of lockdown so far. So I think whatever you are able to deliver is certainly better than nothing at all, and we can adjust as we go through this journey, patients and clinicians together. So yeah, I mean, it's helped me, and I'm living proof that a digital consultation worked for me. No, it's not going to work for everybody, and not everybody can access it, but I don't see that as a justifiable reason not to do it. Yes, we need to look out for those people that can't access or won't, and those people most certainly always have to be considered. But the majority of people these days can access this kind of thing, so we need to jump on that. And I think it will save everybody time, stress. From a patient's perspective, the difference between attending a clinic for an appointment or sitting at home in your armchair is vast. You haven't got the stress of worrying about attending appointments. Am I going to get there in time? Am I going to be able to park? Am I going to be able to find a seat in the waiting area? How long will I be there? All these things add to your stress. And believe me, people in pain sit and worry about this days before the appointment happens, because when you're living with pain, those what appear to be small things to everybody else turn into huge blocks that we have to overcome in order to just attend an appointment. So the fact that people may be able to be offered this type of appointment is going to be amazing for most of them. So yeah, I would just encourage you all to grasp the nettle. You're going to be great at it, and if you feel that you need extra resources, whether that be training or IT support, ask for it, because it is a really valuable thing you're going to be able to offer. I think that's really all I've got to say. I don't know if I've done my 10 minutes, Jackie.
You have not, but you've done very well. Thank you, Louise. So you did that in 6 minutes, so excellent. Thank you. So if anyone's got any questions for Louise, if you can just pop those in the chat box. Gives me a bit of an opportunity to do some housekeeping that I forgot about. I'm just going to say that we've got a few people in the waiting room, if my colleagues would like to admit them, if you're listening. Lovely.
Yes, all admitted.
Excellent. Oh, there's a few more. They keep coming in. So I just wanted to say to everybody, the prospect of Zoom bombing does exist for us. So I'm just letting you know that if anything unsavory does happen, we have a team of people all waiting to hit the end button. So if that does happen, we will stop the meeting and try and reorganize that. But hopefully that shouldn't be a problem. So without further ado, I'm going to bring up our next speaker, who's Leila Heelas, who is the speaking to us from Optimise in Oxford. I'll let her introduce herself. The title of her talk is Clinician and Patient Experience of Virtual Consultations and Early Feedback. Excellent. And I'll just get Dermot, if possible, to stop his video.
Okay, shall I start?
Yes.
Okay, yes, so I'm Leila Heelas. I'm clinical lead with Optimise Pain Rehabilitation and Unit in Oxford, and I'm going to just present some early feedback from patients and clinicians and their experience with virtual consultations. And very kindly, Dermot Dennehy has given me some data from UCLH Centre for Pain Management, and so has Anthony Gilbert from the Royal National Orthopaedic Hospital. So the CSP have already given us a lot of very useful resources about virtual consultations, but the Health Foundation website is another really useful place for finding information out. And the Q community have a selection of blog posts, videos, and directing to research papers. If you haven't found it already, I'd recommend having a look there. And the Barts Health NHS Foundation Trust have got a lot of experience with virtual consultations, and they've put their health feedback survey onto the Q Community website. And you may wish to use this if you haven't started surveying already for some ideas of what questions to ask. So at UCLH, you can see from this that most people who accessed video calls rated the communication highly. They found it easy to access the video clinics, and they would be open to having another one. And we found similar results in our service. And some of the qualitative feedback from our survey tells us that patients felt valued by being contacted by us, and also they felt that they hadn't been forgotten. So both UCLH and our service asked patients what were some of the best things about their either video consultation or telephone appointment. At UCLH, they were all video consultations, and we used a combination. When we called 50 patients initially, only 3 wanted video consultations, but later this converted a little bit more after their first telephone conversation. And you can see from this that at UCLH, the possibility of not having to commute and saving time was a very favourable aspect of the consultation, and this has already been highlighted by Louise. We also asked about parking, which is also highlighted by Louise, because many patients tell us that they find it really stressful, or if they arrive late, they get very worried about that. And we also had a section for qualitative input in this question. And again, patients highlighted that they valued not having to travel long distances when they were in pain. So at UCLH, patients were asked how the video call compared with a telephone clinic. And you can see that most found it more favourable than being spoken to on the phone. And we asked how the virtual consultation compared to a physical clinic. And you can see that roughly 50% would find it either the same or better than a physical clinic. But about 40% were unsure, and that's possibly because this survey was sent out after their first appointment and they were new patients to the service on the whole. So that's maybe it is why it accounts for that uncertainty, as they hadn't accessed our service before. We also asked people if they would like a virtual clinic as an addition to the service, and most would. Most found that the privacy of the appointment was adequate, and most felt they were able to communicate everything they wanted to. However, again, in some of our qualitative feedback, some people said that they weren't able to talk freely, and we had a number of safeguarding incidents, and it may have been relating to this. So at the Royal National Orthopaedic Hospital, after video calls, patients were asked and clinicians were asked what their preference would be for the next consultation. And you can see it's quite interesting. It's almost identical in the responses. So about 50% wanted face-to-face and about 50% were happy to have another video consultation. And that was a large number of participants. There was also some qualitative feedback from the RNOH, and there was some similarity of themes for both patients and clinicians. Many said that they found it was a really good audiovisual experience, and many patients said they were so pleased to have access to excellent clinicians, and the clinicians were very pleased to deliver high quality care to patients. The physiotherapists in particular really found it valuable to demonstrate exercises, and all clinicians valued the opportunity to undertake a physical assessment. And patients reported that they found it helpful to learn exercises, just as Louise did, and also they found it useful to learn exercises that could be done in their home environment. Convenience was cited as another beneficial factor, and again, reduction on the need to travel. But not everything was so positive. So many people reported problems with audiovisual quality and with the videos cutting out. Some clinicians reported difficulty with the accuracy of assessment and were frustrated that they couldn't palpate in certain assessments. Some patients had difficulty with manipulation of equipment to show regions of their body. There were sound delays which affected communication, and also hardware problems such as lack of access to wireless headphones or laptops. And some of the patients reported problems in their own environment, such as having small screens. So patients were asked their perspective on what could be better. And of course, audiovisual quality was in there. And patients also wanted larger screens. They asked for guidance on how to use some of the software, or perhaps have a test call or the link to attend anywhere embedded into emails. And some of these things would be quite easy to implement. And I know on discussion with clinicians, many are speaking to patients on the phone and then converting to video calls part way through. And also patients asked for an indication of waiting times, because some patients were left for a very long time waiting, and at times didn't even make contact with the clinician, and that's also occurred at our hospital as well. And so if we could help patients with that, I think that would be really helpful. So this paper was published in May, and it actually is about consultations in diabetes, cancer and heart failure services, but there are some lessons which I think are universal. And it looked at the linguistic changes in video-mediated interactions. And overall, it was an unusual study because they looked at interactions at the patient end and the clinician end by using recording software during the consultations. And they found that the consultations were effective, but that there were 3 areas of challenge. So firstly, establishing a connection and starting due to connection problems, which sometimes made the consultations quite stilted, and this was stressful for both clinicians and patients. But conversely, sometimes this resulted in humour and a more informal interaction style. And this problem was solved by shutting down the consultation and restarting. There are also disruptions to the conversational flow, and this was often caused by software or Wi-Fi issues. And this led to people talking over each other, or the communication with large pauses. And this potentially resulted in quite a serious problem in that a patient didn't understand a change in their drug regime. Luckily, this was rectified later in the consultation. And this perhaps highlights for us the importance of using teachback in virtual communications. Lastly, there were problems with physical examinations. And I know in some of the qualitative research from the RNOH, people with disabilities found it particularly difficult to manipulate the cameras to show the region of the body. But there are also environmental problems like lighting, low seating, making physical examination difficult, and objects in the home getting in the way. So perhaps that's something that we could try and address with patients before the virtual consultation. The Q community have recently released this blog that says, although there have been many positives from virtual consultations, there are still some concerns. So there's an increased unease about inequality. There's some evidence to suggest older people are less keen. Also, there's inequality in access to software and hardware. And also there may be language barriers which would preclude patients from attending. But at Barts, what they do is they use a bilingual health advocate who's trained in virtual consultations during the call to overcome these barriers. There are also some concerns re safety, and this was with regard to safeguarding issues, and I think this is something we need to think about. And we're now moving into a phase where we are running face-to-face services with digital services, which is going to be an ongoing challenge. We've also found as a team that some of the calls are quite demanding on an emotional level, and that we've been working very long hours, and this may lead to sustainability problems in the longer term. And the Q community are worried a little bit about how this may impact on quality of life at work. This infographic, which is a health footprint of the pandemic, was developed by Victor Seng. And you can see that in the third wave, it's suggested that there will be an impact on chronic conditions, and we don't yet know what the cost of self-shielding and self-isolation is going to be on physical health. And the fourth wave may be the impact on mental health, perhaps due to economic hardships, clinician burnout, but also the stress of living in a pandemic. And what I wanted to finish by saying is that although there are challenges, virtual consultations are very positively received, and we have skills in both physical and mental health that we can use usefully to mitigate some of these long-term impacts. And I'd like to thank my team and Dermot and Anthony in particular for being so kind just to share their data.
Thank you, Leila. That was brilliant. So any questions for Leila in the chat box, if that's okay. And I will now invite our next speaker. This is Anthony Gilbert from the RNOH, and he's going to talk to us about rapid implementation of virtual clinics at his setting. And I'll let Anthony give us the details of that. Go ahead, Anthony.
Okay, thank you very much. I think I've managed to share my screen okay with you all. So I'm Anthony Gilbert. I'm a physio at the RNOH in Stanmore, and I'm currently doing an NIHR clinical doctoral research fellowship at the University of Southampton. Clinically, I'm based within our elective orthopaedic service. As my PhD is on video conferencing, I was asked to help set up virtual clinics, and I'm going to share some of my experience of this with you today. Okay, so just want to say this is a massive team effort, and I want to acknowledge the project team, a whole load of people at RNOH, but particularly Andrew, Jaggy and John Doyle for their support with this, and also the patients and clinicians, because it's been a really challenging experience for many people. So, you know, we couldn't have done it without everyone's engagement, and also my PhD supervisory team have given me a lot of support on this too. So sort of reflecting back on all of this over the last few months, I still think it's a bit strange how everything sort of came together as it did. And reflecting on Louise's talk first, and thank you, Louise, for sharing your experience. I think it's worth emphasising that what I'm about to talk about was done in response to COVID. And if we couldn't see people virtually, then they would potentially miss out on their care altogether. So we started to look at this project in early March, and what I'd say is that strategically, this is something that the RNOH was looking to do anyway. We'd secured a license to attend anywhere in February, so we had a bit of a head start before things started to get quite busy with COVID. On the 5th of March, the hospital leadership team set a target of 80% virtual consultations across the trust. And we only had an 11-day lead time on this. For others like myself who are undertaking research that relies on routine outpatient appointments, this is quite sad and challenging moment for me. But there were lots of conversations about virtual consultations, and finally we had a group brought together on the 11th of March. And this is one of the key points I would really like to make to you all. We had a team of operational management staff, myself as a clinician, and I'm doing my PhD currently looking at virtual consultations, so I suppose this is my area of interest. We had a project manager, we had QI experts, and one of our fantastic volunteers, so we all came together. And other than the ops staff, who were obviously very busy spinning many different plates, we were all allocated to this project as our job, so we're given the resources in order to do it. I think this is key to the success of getting it rolled out so fast. It does need resources. Currently, our pain management program team are looking to run a program virtually at RNOH, and I keep on saying to them that the project managers leading this, who are both physios, need to be given the time to run and support the rollout of this, and to be able to evaluate it, particularly as they pilot it in the early stages. And I think this is a key message for anyone looking to roll virtual clinics out, and I can't emphasise this enough. I mean, what we did was pretty straightforward. We screened all of the clinical lists. Patients were called by the admin team and given the option of a telephone consultation or a video consultation if they were to have it virtually. If they were needed to come in for whatever reason for their appointment, and they were told that their appointment was still going to go ahead. Our IT team were absolutely superb and updated pretty much every single computer across the trust so they could run Attend Anywhere, which is the software we used, and they deployed all the webcams and headsets. Our project team set up user accounts for all the staff, and we set up how-to guides to make it as easy as possible for them. And when we were actually rolling it out, we had floor walkers supporting the clinicians. If any patients got stuck, then we as the support team would phone patients and help talk them through it. If they're having difficulties getting on to Attend Anywhere, and ultimately if they weren't able to get on, then we were communicating with the clinicians to let them know that they needed to do it as a phone call. And we did our best as a team to make this as easy as possible for all the patients and clinicians. Prior to this project, I'd never used QI methodology before, and this is really my second take-home point. It was really useful and important we did this in an organised and structured way. So we used PDSA cycles as a framework for improvement, and we worked through these in real time as we identified issues. My third take-home point, it was really important to have that we had daily meetings. We had teleconferences scheduled for 11 o'clock in the morning each day and 4 o'clock in the afternoon each day. So I mean, this is quite a lot, but everyone was present. And you know, to have the operational managers there, you know, were really able to help us to unlock some of the key issues we had, and they were able to call in the information governance team or the IT team or whoever we needed in order to help us to solve these problems. Lucy Davies is part of the project team. She's our Chief Operating Officer. She gave us some really useful support. And although she wasn't able to be on all of the calls, she was available to us if we needed her to sort of really try and push some things through. And what I'd say is these projects can't really be done in isolation. It's not something that an individual could do. It really does need an MDT. So for this section, I'm going to talk to you about the bottom line outcome for our project. All of these results are in our paper that was published a couple of weeks ago, and I've put the link up on the slide. So please do take a look at that if you want some more information. It's open access, and if you'd like me to email you a copy, then my email address is on the final slide, so do get in touch. And just a reminder that for this, virtual consultations were both phone and video. It's not just video calls. We set a target of 80% for virtual consultations, and you'll see that we hit 85% virtual consultations at week 2, and since week 3 we've maintained more than 90%, which is a great achievement across 2 sites in our trust. The majority of these were telephone. Between the patient and clinician, or the clinician initially were offered the choice of a video call or a telephone call, and then the patients were offered the choice. But it is striking to see that so many of these were telephone consultations. And I think we all do need to remember that video conferencing is quite hard, and in many cases it is easier for a patient and clinician to have a phone call. My PhD is looking into this, and I'm still a bit of time out before I'll be able to share any results. What I will say for some is that video calls can be quite burdensome on both patients and clinicians, and this may potentially influence preferences, why so many chose video calls. Okay, so this graph just demonstrates the proportion of virtual to face-to-face consultations for the 2 weeks before we started this, just gives a bit of a baseline, and then the 6 weeks following. This graph demonstrates the proportion of telephone and videos as the overall proportion of outpatient activity. And I'm just whizzing through these because I don't want to be told off by Jackie, but all of the information here is within our paper. We did a rough and ready survey monkey in the early stages, and what's really good about Attend Anywhere is it's got a useful function that you can put a link to a website when you finish the call. So for all of our patients and clinicians who had a video call, they were sent to the survey monkey to fill out, and this gave us some really useful evaluation data. Something that really interests me, and it's sort of my PhD topic anyway, but it was whether or not patients and clinicians would prefer face-to-face or virtual consultations next time. I thought it was really interesting that many in the video group would opt for a face-to-face if this was possible. And we're doing an in-depth evaluation study sort of next or coming very soon, where we're looking to unpick the reasons behind this. And as you'll see, that satisfaction scores were generally pretty high across both groups. So I suppose the key take-home messages from our experience, the use of QI methodology was really important for us. We did a lot of PDSA cycles, which is spelled out in full within the paper, but I've got a couple of, I've got some examples here. But essentially we use PDSA to help us to standardise and improve admin processes, to help us to develop training resources, to deploy and to develop the technical infrastructure for the video calls. We worked on the clinical pathways. So as an orthopaedic hospital, we have lots of stuff going on before a consultation, then after. We've got people having surgery and whatnot as well. So we needed to try and unblock some of this, particularly when it came to things like imaging and bloods and transport. And we did a lot of work on patient and clinician experience. So as we got real-time feedback, we were on a daily basis trying to improve this wherever we could do. And I don't think it would have been as successful without using sort of this methodology. And I would urge everyone to look at this if you're considering rolling out virtual consultations. Resources are really important. I don't think there are any shortcuts that you can make. If you can, throw as many staff or as many helpers as you can at this, particularly in the early stages. For us, an MDT approach was made this a success. And I think that staff do need to be dedicated to the project, particularly in the early stages. I do appreciate that not everyone is going to be in the same position that we were at the RNOH. We don't have an A&E. We could plan ahead and we're able to control the flow of patients through the hospital more than others could potentially. But if it's for a short period of time and in your trust or service, I would urge you to have a small implementation team to support the work. From a resource point of view, we use loads of webcams and headsets, and it is really expensive in order to do this. In terms of resources, having really engaged staff who all really pulled together throughout this was amazing, and we couldn't have done it without that also. From a project point of view, communication was really important. We had regular meetings so we could troubleshoot issues. I found in my hospital don't have any phone network, so it was all on Wi-Fi and WhatsApp calls and what's not and whatnot. So I'd advise anyone using their mobile phone to communicate with the project team to get power pack, because my battery ran out quite regularly. There's a lot of exciting and interesting work to follow all this, and I think forums like this is amazing to share knowledge. We're looking to evaluate virtual clinics, and my PhD work is ongoing, looking at preferences, and I look forward to sharing that and evaluate what we've done very soon. So I'd just like to thank you all very much for listening. We've developed a video for the NHS that anyone can use, and it's specifically for Attend Anywhere use. So the link is on the screen, and I can circulate this after. And if anyone wants to get in touch, my email address is on the screen. And also a little plug for my PhD website. Got some ongoing work going on video consultations. So please check that out if you're interested. And thank you very much for listening.
Thank you very much, Anthony. Great timing. So if anyone's got any questions for Anthony, if you can just pop those into the chat. And that's it. And I would now like to invite our next speaker, who's Emma Mir, and she is going to talk to us about exploring barriers to digital rehabilitation. Emma.
Sorry, I realised I had to put my microphone on before I could share. So. Hopefully that's me all set up now and you can hear me. So thank you for the PPA for inviting me to speak today. I will be sharing my personal experience, but just wanted to acknowledge my colleagues within the Scottish HP Pain Management Network for their contribution. So I'm a pain management physiotherapist. I work in NHS Ayrshire and Arran in Scotland, and I also have a role within Scottish Government in supporting pain management and primary care. Our service was very under-resourced prior to COVID-19 pandemic, so we were aiming to have some service redesign and development, but then like many services with the pandemic, our service became even more limited with redeployment of staff. So I'm absolutely not an expert, and I've certainly been conducting more telephone consultations, but with the option to switch to near me, although they've been much fewer to date. Although I'll be focusing on the barriers, I cannot say that there's not been huge opportunities as well with digital options. It's allowed us to connect with individuals within our service that we wouldn't have been able to otherwise, and everyone has been very appreciative of this. It's been an option for those that travel considerable distance within Ayrshire to attend appointments, that this might become embedded in our service as we go forwards. And we've also been able to look at exploring virtual groups, which we hadn't been able to deliver with a resource prior to having the option of digital. So Ayrshire and Arran is in the southwest of Scotland, and it's a large geographical area. It includes rural and island communities, and I live and work in Ayrshire, so I apologise if I'm speaking a bit too fast. Part of that is because I am Scottish, but also I have to fit quite a lot in within 10 minutes. So the Scottish Index of Multiple Deprivation takes into account not only the financial but opportunities to engage with education and health, and all areas in Scotland are ranked on this. Within Ayrshire, one of our areas is deemed deep-rooted deprivation. That means that it's consistently within the top 5% most deprived in Scotland, consistently since 2004. And unfortunately, with the more recent data from 2020, it also sits within the area with the largest increase in deprivation since 2016. I acknowledge that within Ayrshire and probably within some of the areas that you work, you'll see there's quite a spread across the area, that you have a range from those that are most deprived to the most advantaged. But within our service, we receive 60% of our referrals from this area. And we also sit at the highest in terms of prescribing rates for pain medication in Scotland for opioids and gabapentinoids. So we sit at the top of the league tables you probably don't want to be on. So we all acknowledge and know that the social economic factors are considered significant risk factors for persistent pain, and it's recognised that people in the most deprived areas often have more health needs, including persistent pain, but they're also far more likely to be prescribed opioids, and that's 3 or 4 times more likely. So that cannot be merely explained due to their locality. I guess living with extreme deprivation and coping with the multiple stresses associated with that, especially if that includes basic needs of food and shelter, it does mean that people are potentially disadvantaged to be able to engage fully within self-management strategies. And we should always be taking these factors into account at all times, but more often healthcare systems put up some barriers and make that a bit challenging to do with some of the processes involved. But then we fast forward to COVID-19, when our only option in our service was to deliver what we could digitally. I've been really surprised in terms of the number of individuals with poor access to technology, who don't have equipment other than their own landline phone, have a mobile phone without internet. And this has been acknowledged by the Scottish Government, and they've developed a Connecting Scotland initiative where individuals and organisations can apply for digital support for equipment, but also for broadband packages and the data that support. I'm not going to labour the points in terms of Wi-Fi signals and these sort of things, because we'll all have experienced that in terms of even joining something like a webinar today. I think what is more key is the literacy to be able to use the technology, and that includes me in that, asking individuals to switch platforms from their Internet Explorer to Chrome to be able to go onto the Attend Near platform was something that I couldn't work out without support. So it also brings in that clinicians' IT skills. And I'm sure my colleagues, if they're listening, will be laughing how far out of my comfort zone I am even presenting virtually, when normally they have to show me how to use Twitter. So it's pushing the clinicians out of their ability, not only for them to be able to access these platforms, but also that then they're able to support the individuals within sessions. And I think the training needs have to be really appreciated as part of this. People often refer to that ability to be generational, but I think you'll find that is across the board. Older individuals might be far used to using Zoom or Skype to connect with family across the world, but I do think we often make assumptions that people of an older age will choose not to use video, whereas I think we have to be able to find the individual preference for this. I certainly have heard colleagues saying that person is in their 70s, so we'll just put them down for a telephone call, whereas they might be better than me at using video. And also, I suppose, with the rapid implementation during the lockdown means that there was no other support available. Often people would say to me, if I was able to have my family here, they would be able to show me how to get online and access the exercise videos, etc. And we would normally have supported people through support services, including libraries. I guess the environment also needs to be considered for a few reasons. First, we are entering into someone's home environment, and that goes vice versa when there's often a lot of clinicians working from home at the moment as well. And certainly some of my colleagues have raised that apprehension of even inviting a colleague into, a client into their home, even by telephone, that they just felt they felt different about it. And patients feel absolutely the same. I don't want to go in video because you'll see my messy house. I'll have kids running about, and having the kind of other demands of homeschooling and childcare to juggle at the same time on both sides too. It's important, I guess, to remember that it's still an appointment, and people need that space to be able to discuss often quite sensitive matters, and also to raise the confidentiality issues of who else is in the room on both sides of the call. I've certainly had to deal with people who want to have a chat with me as they walk around the supermarket, or they'll go and answer the door in the middle of the call and don't give the attention as they would to an appointment. And I think that's been a learning curve to be able to set those ground rules, especially within group settings. Research has also shown that it's much easier to build a rapport on video if you've met with the individual before. And I suppose with my apprehension of trying out this new technology, that's probably where I started. I connected first with people by telephone and then switched to Near Me. But if I was going on to Near Me, I tended to choose people that I had previously met face to face. And maybe that was just because I had developed a relationship with those people, that I wasn't as apprehensive if things went wrong, how it would reflect on myself or the service. But I was pleased to hear, as Louise was saying, that people are forgiving of this, and I think it's more our apprehension than anything else, and everybody does feel they're in it together, trying it out. I think the art of kind of developing relationships is key in a lot of the kind of coaching roles we have in behaviour change, and that certainly does take a bit more effort when you're doing that digitally without being physically present. And I think that the digital fatigue has been well reported within the media, but I guess for clinicians who are dealing with maybe digital consultations all day and then also using virtual means to be social in the evenings, I think that can be very draining on people, and I think it has to be acknowledged when we service plan in terms of planning for clinics so that there's breaks and there's different activity if possible. Learning needs always have to be considered with any consultation, and I think for some that might make it more difficult, but also for others having the option in terms of having video, I think that's really helpful because they maybe struggle with the written word. So I think a lot of people have found that mixed message of video and text helpful. I know my preference is normally to draw things out for patients, so I've had to change my kind of style a bit as well because they can't see me waving my arms about on the other side of the telephone. I think people have already raised the challenges with people with additional needs, particularly for vision and hearing, and even with video, quite often with the quality that's difficult if people are lip reading. We in our service unfortunately can get interpreter support on video, so we have to do that all over the phone for those who have English is not their first language. And I guess I also wanted to mention that as physiotherapists that are rehabbing individuals in behaviour change and activation, that raises a lot of challenges with lockdown for some of our more avoidant clients. It might be easier for them to connect digitally, but for the activation of movement and activity and challenge, coming out to appointments can be very much part of their rehab, and certainly we've had to address a lot of that when I'm maybe speaking to some of my clients who are still in bed during the day, and how we can start setting goals in terms of them maintaining their activity levels and goals. So I apologise for this very quick tour around a much wider topic, but I think it was just so important to raise some of these barriers, especially when services are starting to talk about resumption, to take into account the population that we deliver services for, but really to make that access to treatment equitable so that we don't widen the gap of inequality, and very much so that we don't miss the opportunity to engage with those who potentially need the service the most. Thank you.
Thank you very much, Emma. That was a great run through of some of the more challenging conversations that we've not really had a chance to have. So I'm going to now introduce Selina Johnson from the Walton Centre, and she's going to be talking about reflections on team support for virtual consultations.
There we go. Thanks, Jackie. So my name's Selina. I'm a physiotherapist that works at the Walton Centre in Liverpool. I'm invited today to speak about reflections on team support for virtual services. So during this time, I'm sure we've all felt the pressure to continue doing our jobs well, keep services running, manage waiting lists, and get virtual services up and running as soon as possible. And what I want to do today is just present our experience at the Walton Centre in Liverpool that is undoubtedly very similar to many others out there, and reflect on what aspects outside the clinical caseload and the actual virtual consultation that have been important and helped us keep going as a team. So this slide just explains what our services were like prior to COVID. So our pain services split into two arms, the pain clinic and then the pain management programme services. And we're now at the stage where we're running video and telephone reviews for all our outpatient clinics. Our pain management programme is temporarily closed, except for our individual patient programme, which is running virtually. And we're in the stage of developing virtual P&P to begin over the next month.
Give me another 5 minutes of this.
Okay, during the 3 weeks when our services stopped, as I'm sure was the case for many others, we constantly received updates, new information, and this meant that plans needed to keep on adapting. When it was clear that services needed to be offered remotely, lots of preparation work happened, and I've tried to list
Sorry about that, Selina. We've got someone on the call who's not muted on a Galaxy A20e. Jeremy, I'm not sure if you can mute that participant. Thank you.
Okay, so when it was clear that we needed to offer services remotely, lots of preparation work went on, and I tried to list some of the important points on this slide, and some of these things are what Anthony covered in his talk as well. So these are all the how-to of delivering virtual consultations, and it is very time-consuming. Obviously, all of this has an impact on the team and the staff, and I think one thing we all know is that physio works for chronic pain, but if you change the situation and how we deliver our skills, as Emma alluded to, it can lead to a lot of anxiety and uncertainty within clinicians and the team themselves. And there's a growing body of evidence to support the effectiveness of virtual working, but not much that looks at what teams and clinicians need specifically in terms of support, other than the things that are listed on this slide, like IT training, risk assessments, and help with triage decisions, which I'd listed on the slide before. So what were our team anxieties? Well, these were perhaps the most common anxieties and concerns that at least I was made aware of. I know redeployment was a big concern for a lot of staff members at the start. We have quite a big team and we have quite a big age range in our team. So a few members of staff perhaps haven't been on wards for 15, 20 years. So it was obviously a little bit more anxiety provoking for them. The ones I've highlighted in bold, the three I've highlighted in bold, are concerns that I think have been fairly consistent over the whole period that we've been in lockdown and that we've been trying to adapt to the COVID situation. Whereas the ones I've highlighted in blue were more from a physio's perspective and really were around how we can function in a virtual way as an effective clinician. And then the last two on this slide are things that hopefully have got a little bit easier with the passage of time. So these are some of the different support structures that we've set up and that have continued. Initially, we used Zoom as a platform, and then we've moved to MS Teams. As time's gone on, I think we've all suffered as a team a little bit of meeting fatigue. And so some of these meetings have reduced in frequency, like our MDT PMP team working. That was fortnightly, it's now going to monthly. And the team learning sessions as well, I've switched from fortnightly to monthly as well. Okay, so looking at the professional team meetings, I think they really gave us an opportunity for formal and informal peer support. We had smaller working groups as well, and I think they were really, really useful because sometimes in a larger group, you may not feel as happy reflecting positive experiences, perhaps the insights, or even some of the negative experiences you've found from remote working, but you may be happier to do that in a smaller group. I think the groups have been really useful in helping to share and normalise our own experience of this, and to know that modification isn't always smooth, but that's okay. I think talking as a team as well, we really started talking about our skills, and as some of the other speakers have said, we begin to talk about this as an opportunity. The virtual way of working can be an opportunity. Particularly as clinicians, we specialise in supporting people to manage biological, psychosocial stresses that negatively impact on quality of life and function, and therefore we're well placed not only to support people manage the impact of pain, but hopefully the impact of the corona crisis as well. I think in terms of managing expectations, standard operating procedures and protocols, as Anthony was talking about in his presentation, have been really important, helping staff get their head around what they're going to deliver. But I think as well, patient information leaflets and developing those has really helped us to think what patients may need. And this has helped with some of those expectations that Emma talked about, so that everybody feels the expectation of the service is a little bit clearer. People know what they're signing up to. And I've just put on here just a snippet of one of our patient information leaflets, and I think Claire's going to make that available on the PPA website so that other people could use that as well. I think being aware, the team meetings really help people to feel aware of changes as they were happening rather than finding out secondhand, and being able to feel that you're feeding into that in some way. And I think the flexible working and the ability to flexibly work, what staff can deliver to support the clinical priorities, and whether that means that clinic templates have to change and flexible working needs to happen, then that's really helped staff, reassure staff. I think there are obviously some cautions or challenges when using virtual platforms such as Team and emails a lot more heavily. We sometimes lose some of those subtle day-to-day informal reassurances that we rely on when we're working day-to-day. And so there is that area that sometimes things get miscommunicated maybe a little bit more easily. I think we've had some optional coffee mornings as well. I think these have been really important. We spend a huge part of our day and our week at work, and sometimes we see co-workers more than our family. And we miss, when we're not in that situation, that informal opportunity for communication and support. And I think these coffee mornings just allowed that to happen, even if you didn't dip into them all the time, and build a sense of community. Oops, sorry, skipped one by. Last year, as part of our team training week, we ran a series of sessions looking at burnout and thriving. And as a team, we spent some time talking about the issues that prevent us from thriving, and how we can conduct our supervision sessions across disciplines. I think this has been particular, and some of the things we talked about are the things I've listed on this slide. And I think that's been particularly useful now, particularly as during a crisis, our emotional stability is often quite up and down. And I think there's been a need for us to make sure that supervision is very regular in the formal capacity, but also there's probably been a lot more informal supervision happening. And I think that's been important. We've also run some MDT team training sessions, and these are some of the topics that we've covered. I think they've been really, really useful to discuss some of these topics. We also had an Attend Anywhere training session, which I don't think most of the team found particularly useful, but the discussions around why that were useful. I think one thing that we've discussed a lot as a team, and this was really important, are the boundaries and the barriers. I think the team meetings have really helped us filter some of the information that's out there on that. There's a lot of information out there on Zoom fatigue and Teams fatigue, but talking about it in team meetings made it more digestible. It helped us to consider some of the things that we need to consider and share tips and best practice. And I think, as Emma said before, most of our social roles prior to this probably happened in different places, but now it's all happening around our computers, and that in itself can be really exhausting. And so there is a need to have boundaries in place and to protect our different social roles. And I really like the statement that I put on this slide, because I think that really nicely sums up that it is a different way of functioning that we're doing, and we need to understand that. I think sharing information as a team has been really useful as well. It's taken, as a team, what we've ended up doing is tidying up our shared drive, and to make it that information that's valuable to share with patients and the team a lot more accessible and easier to navigate around. So it's been useful to have different leads within the disciplines to organise folders, and then to have a general folder to make that a lot easier to access. And as Emma said, everybody's got a different level of tech savvy. So if knowing through the team meetings maybe who are more confident with certain things has given people other points of contact, people that they can go to if they've got any questions as well. This slide just represents some of the information that we shared, and I think the CSP links and the PPA links on different resources I think are on the PPA website already. So in terms of team reflections, I think as much as it's about supporting patients, it's also about what we need to consider, the non-clinical aspects to make us good clinicians. And that means pulling our teams together to make sure we deliver the best possible care and what this may take. I think we've got a really good skill set as chronic pain clinicians that can help patients within this situation, and it could be an opportunity to use those skills to support patients at this time. Structures obviously need to be in place, and I think the team meetings, supervision, teaching, even WhatsApp groups between members of staff have been really useful at this time. I think as well, regularly checking in and often outside of those meetings has been really important as well. Again, sometimes an email, somebody may have taken it a certain way, and when we check in again, it just helps to normalise some of those experiences. We forget how much we used to rely on just knocking on somebody's door and talking about our day, and we're losing that in this situation. I think setting barriers and boundaries has been really useful, and honest reflections have better reassured anxieties. We don't need to know that things are sunshine and roses. I think we were aware that we are performing differently in a very different situation, and it's going to be up and down, and that's okay. Okay, that's everything I've got to say. Thank you.
Thank you very much, Selena. So I'm now going to invite Claire Jacobs, who is from the Input Pain Management Services, and she's going to talk about supporting patients using online resources. Claire.
Hello, can you hear me there? My name is Claire Jacobs. I'm the physiotherapy lead at St Thomas's Input Pain Management. I want to talk about supporting patients, and actually hearing Louise talk at the beginning is really interesting and useful to just remember how much stress and worry patients have coming to appointments.
Apologies, I'm just trying to find out who's got their mic on, sorry.
Okay, so I'll continue. So finding out what's important to our patients. So through focus groups, through patient surveys taken over different experience pre-COVID and also during COVID, tapping into what patients need, how to decrease that stress and worry of coming to an appointment, but aiming to improve integrated care. How can the care that we offer be coordinated? How can it be personalized so that we have good patient contact with clinicians and that the patients do feel supported? How we improve accessibility to treatment, so reduce some of the practical barriers that my colleagues have alluded to of attending face-to-face treatments, such as distance, childcare, employment, and also being able to respond appropriately in the pandemic we have now and in possible future second waves and different things that happen. Helping to decrease waiting times, but also to support better outcomes. So aiming that more patients can get flexible and timely access to multidisciplinary pain management. And also to facilitate the patient's capability to develop pain management skills. Also costs, so looking at efficient use of resources. So a little bit of a recap on where we've been in terms of our approach at Input. We have, like most people, started doing virtual attend anywhere assessments, mainly physiotherapy, psychology, but with the case management input of occupational therapists and nurses. The ones that I've circled here in orange are ones that we've moved to virtual. So we have a 3-week residential and a 5-session ACT-based outpatient program, all of which we're moving to virtual platforms. We've had the typical barriers of information governance and finding the platform that's most appropriate. So these are due to start in June. And we also have individual waiting lists. And prior to the COVID, we were already looking at redesigning our neuromodulation pathway to explore the option of an online technology day to better support our patients in this, with all the moving forward with the trial. The ones I want to talk about today are briefly the follow-up, but also mainly the online individual pain management that we have. So our virtual follow-ups, we've actually been doing for some time now. We developed this following pilots in March 2017 for our neuromodulation programs. And this has involved sending questionnaires online with checking whilst patients were on a program in terms of their relevant information, in terms of reading, writing, computer access. And then following up at the end of the program at either 9 months or 12 months with an online virtual questionnaire, and then a criteria for screening the results we got for the questionnaires. When we send out questionnaire data, we don't want to send anything that people are not able to know and that we can't respond to if risks are shown as part of that. So we had different criteria for that, if there were cause for concerns or if there was a request to speak to a therapist. Some of the brief feedback we got was that follow-ups are an important safety net for picking up potential problems, but also when people are filling out questionnaires in their own time, that they don't have someone hovering over them, and it was much better as they could break it up rather than having to do it all in one go. What I want to talk about today is the online individual pain management program that we're running at St Thomas's. This was a feasibility trial that was started back in 2016-17 by Dr. Whitney Scott and Lance McCracken. It's a feasibility to introduce a trial of online acceptance and commitment therapy for patients online as a way to make something that was flexible, easy to use, on process, that our patients could use within their own time, but it was also supported by clinicians. So a little bit about the trial. There's more that you can read up about this. They trialed 139 participants, of which 63 were eligible and were randomized. 61% completed treatment. Of those, 44% were employed as compared to 80% unemployed. From the trial, 56 rated themselves much improved or better on the global impression of change rating. And they had small to medium effect sizes for maintaining functioning, healthcare use and committed action at 9 months. So from this, the feasibility study was then commissioned to provide treatment pathways to better address the diversity of our patients' needs and to provide more personalised care. So this was already up and running and has been up and running for some time prior to COVID. We've seen 60 to 70 patients within the last 2 years. It properly got up and running since January 2019, and it's been run by psychologists. It was picked up since COVID-19 and 22 patients have been seen since mid-March. The difference here, and I'll come back to this in a moment, is the fact that now it's been open to our multidisciplinary team, and our physiotherapists and our occupational therapists are now being part of this. It's early days in terms of collecting data, and they're waiting for more before this. And there's also a similar dropout with the trial data. So the platform is called Act for Pain. It alludes to the principles of ACT of being open, aware and engaged. It was set up as a psychology-led, clinician-supported online treatment aimed to be flexibly completed over a 5-week period. It uses pre-recorded audio and video content and has a named therapist for communication and support and very practical skills-based. So this is now, as I've alluded to, has become multidisciplinary-led as a way to, we were finding that we had options of an outpatient program or an online program following a multidisciplinary assessment. And there was a greater waiting list for the online program, sorry, for the outpatient program, as it had a multidisciplinary content. I wanted to include some slides to some screenshots about the program. This is what the patient would see if they were linking in online. They would get a little bit of information about the aim of the treatment, but also about how the sessions are run, who the therapist is, and how the messages are communicated. So how does it work? Initially, it's a telephone call. It's 2 telephone calls. First of all, to set up a more detailed call, which would be about how do they feel about engaging in this sort of treatment, explaining how it works, and also checking in with them in terms of any risk factors or how they, or any barriers that might come up for them for using this type of treatment, such as the ones that Selena's alluded to in terms of their access. It's computer-based. What you can see on that front screen is an example of an audio that they might listen to, and then a couple of comments, a comments box that they can actually write. How did they find that? How did they get on with having a go with that particular exercise that they were exploring? Again, there's no rights or wrongs here. It's about what experiences came up for them. In terms of the therapists working within this program, we have the graph there. We're exploring how they're developing in the processes of open, aware and engaged. So we talk about being present, we talk about leaning into difficult emotions, sensations such as pain, and also doing what matters, so where they are in terms of their values, what's important to them. The therapist's role is a support. It's the content is the key part of this program, and the therapist's role is to respond to comments and questions via text, email, their secured email addresses, and to encourage and reinforce, and to help patients to detect and foster their psychological flexibility. So the ability to keep engaged with what is important to them. So for us with COVID, this has been something that we kind of got onto fairly quickly. We had been wanting to explore the multidisciplinary content of this for some time, so it was also a good opportunity for us. We had some reflections with the physiotherapy and OT team about how they felt about taking on this patient, because the medium is quite different. We've got video consultations, but we've also got how we respond with emails and texts in quite a short space of time. The response rates in terms of a patient would write their comment, we aim to respond within sort of 24 to 48 hours. The team report that the method of communication was interesting but challenging. We have one patient that completes 8 sessions over about a 5-week period. To establish that relationship over text, we all know how easily when you send emails, things can get misconstrued. So you're wanting to actually make sure that you're supporting and you're validating and you're encouraging, but you're also making sure that the questions are open questions. You're not judging what anyone's saying. So you're very aware. So all the skills that we would bring into our pain management in terms of our coaching and our communication are just using this in a very different medium. One thing that I was aware of when we were talking about our reflections was when you get a lot of emails in one go from a particular client, that how would we actually respond if we were face to face? Do we always answer every theme that somebody comes up with? What's our style of questioning? So again, this is just a very different medium, but it's an interesting one to develop our skills in. How much we write, what's the style of our response? And again, remembering what the role of the therapist is. We're aiding the process, we're keeping the patients engaged and on track. Formulation, what's behind the response that somebody writes down? So I had a response from a patient this week, I'm not connecting with this exercise. So how do I respond to that? Was there some anxiety? What did it bring up? Is this something that comes up in different areas of their life as well? So do we just leave that question, or do we actually delve a little bit deeper? So again, formulating what's behind the response. Also, how we feel when a patient disengaged from treatment. When this is someone who just stops responding, doesn't send any more emails or presses stop, how does that make us feel? There may be many reasons behind that. They may just be too busy. There may be other things that have got in the way, or this may not have been the right time for them to approach this sort of treatment. And also remembering that each patient is very, very different. So where we want to go with this in the future, the barriers to the program we have at the moment is that it's purely psychology based and doesn't reflect the broader MDT. I've mentioned that patients are often referred to the outpatient for this reason. And the feedback that we have had from our patients is that we need more MDT content to support wider implementation. So with the future plans for this are to involve the multidisciplinary team and to develop the content. And in the future partner with other NHS providers so that this is something that can be useful for other trusts. It's an innovation in digital treatment. And as part of this as well, I talked earlier about developing an online technology day. This can also be part of the same platform. So our experiences of virtual pain management physiotherapy, again, as we've said right from the start, patient feedback is so important. The others have alluded to this.
I'm going to give you a 1-minute warning.
Okay, so the skills and experience that we have, checking in with the expectations of clinicians and patients, so they're pre-program planning, warning people what this is all about. Shared learning is important. We've alluded to burnout, confidence, but also within the ACT model, sort of leaning into what's important to us. Working within this environment doesn't have to be perfect. Shared learning is important and supporting each other. So again, lots of changes have come in, but it's important as well to take a breath, to consider what's working and what can be put aside. Thank you to the team at St Thomas's, Whitney Scott, for introducing this online, that I think is a very interesting way forward, and that hopefully we can share across wider trusts and also for the wider clinical management and admin team at input. Thank you for listening.
Thank you, Claire. And just to finish off our presenters and hopefully give us some time for questions, we now have Christina Sorrell, and she is a patient director of the MSK Camden service. And she's going to be talking to us about involving people with lived experience in service recovery. Over to you, Christina. You've got 10 minutes.
Hiya. So, hi, I'm Christina. I'm not just a patient director, but actually I'm a chronic pain patient. I'm also the lived experience ambassador for NHS England. And I just wanted to talk about, I'm not sure, Jackie, what you just said I'll be talking about, but I'm going to actually pull together some things that I've from listening today. So I think I need to kind of just bring up some things. So basically, as a patient, especially in terms of when I had situation of being at home for 5.5 years, not able to leave, developed PTSD. Actually, having a digital consultation absolutely been life-changing. I would get ready for one of my appointments. I had multiple appointments, and I wouldn't be able to leave the front door. And if you do that twice, it was a DNA, it didn't arrive, and that, you go back to the GP, go around the circle again. It really wasn't helping my mental health. So I just wanted to kind of let you know that I'm actually involved in the hashtag NHS Change Challenge, which some of you may be aware of. And if Dermot's listening, if you could share the link to the website, you've still got time to add in. So where people have had successful situations, in terms of virtual consultations, it'd be really good to have that inputted, because they've extended the deadline, because the things that we're looking at. So the experience of care team that I work with in NHS England, I am the only lived experience person. There are people with lived experience, but I'm the only person that's been hired with lived experience. And obviously I started in January, and COVID happened very, very rapidly. So basically the situation that I was doing a lot of COVID response stuff. I ended up doing a high-risk patient group, comm support for that. So actually, what we really need to think about is what is the impact. So lots of people talk about the impact, like things like, Zoom fatigue or Teams fatigue. We're living in very unusual circumstances. Everybody is under pressure. Everybody is under stress. So in terms of post-COVID, whenever that comes, things would be very, very much different. So it's a matter of looking at tying it up with other things. So looking at the impact. So when I'm doing the criteria for some of the workshops, I've done 2 today, and I believe Dermot and Louise did a pain one yesterday, is the impact. So I'm just going to read out what it's, so we have to look at patient outcomes, patient experience, population health, and the financial dividend. So with that in mind, then you have to look at feasibility. So that, does it align with the long-term plan? Does it align with speciality-specific strategic plans? Is it sustainable and scalable? So that's what we're looking at. So that made me start thinking a little bit differently today, because as somebody with chronic pain, absolutely, I would like the choice. I don't believe it should go one way or the other. Sometimes, even if you live with people, it can be quite lonely to be chronic pain. Some people don't understand, especially very early on in the journey. Unfortunately, I'm not early on the journey. It's 15 years, later. So for me, I'm probably quite bubbly and stuff. I'm not the usual kind of patient. Me and Louise are very bubbly and quite, we've kind of got to that stage where, we've accepted, that acceptance of your health condition, the acceptance that you have to, they call it patient activation, but it's absolutely the truth. At the end of the day, if you're not activated and as a patient, then it's really difficult. You can't get somebody to change a way of thinking by just say, go and do this. It's not going to happen. So it has to be a partnership. I think that's the thing that really, really works. So in terms of digital consultations, what I found was, I can hear lots of typing in my ear, Jackie. So what I found was that actually it is about thinking about what would work for each person. So it goes back to it being, what is the benefit to the patient? So if you already know your patient quite well, and you know that this is just a follow-up, then really, if you think about if they're on patient transport, they're coming miles and miles away, if you know it's only going to be a 10-minute conversation, then it's a little bit about using that kind of I'm going to say bluntly, common sense, that actually, why not just do it over the phone or a video conference? Some people prefer to be on the phone. So for me, a lot of times you would have seen me in my pajamas. If you'd contacted me when I was very, unable to leave the house, it would have been a better as a phone call. Unfortunately, that wasn't available 5 years ago. So for me, it's that kind of ability to know your patient. If it's somebody new, I think you should initially see that first person, because what's seen on paper can be very, very different to what you see when you meet somebody. So if you were to meet me and I actually gave you my list of diagnosis and kind of conditions, you would probably think this doesn't match. But actually that is the case. And, I work very, very hard on self-management. I have a very good support network. I'm very lucky. Even with other patients and people with lived experience, I'm really lucky that I'm drawn to people that are very similar. But I'm drawn to people that actually want to be positive and kind of make a change, but also want to help others. So I think if you have somebody like that, if you have patient advisory groups, draw them into those meetings. There's no reason why, if you worry about governance, etc., then just go and get some advice from your patient experience team. Because actually, if we're able to do that within NHS England, and we're working with NHS Improvement on this, and we brought patients in, and they're looking at, quite big items, and we're still able to do it. Because it's actually that understanding. It's about building up trust. So if you can work together, then that's that will also help. But one of the things I did write down when I was listening to it, and of course I'm not going to be able to find it now, was, here we are. Basically, I wanted you to think about the personality is always different. So I know that I've got quite a bubbly personality. I also know that I've got a quite fiery personality, and I'm like Marmite. You've loved me or hate me. It's simple as that. But the thing is, I'm quite honest about it. I know my limitations, and hence why I prefer to have more patience with me when I'm doing things, because it evens the balance out a little bit and takes a bit of pressure off me, to be honest. But the thing is, I need you to be aware of your team. So if you're leading a team, and you know that person's really, really nervous about doing a video conference with a patient, and they don't have to be that person doing it, then like you wouldn't force a patient to do something, don't force your member of staff to do it. I think it's about training them, building up their confidence, and maybe getting them to sit in on somebody else doing one, and those kind of things. Because actually, what I've written down here, some people will lack emotional intelligence and interpersonal skills. So at the end of the day, some people are more technical, and they might be absolutely amazing what they do when they've got a patient in front of them, but put them in front of a camera and they absolutely freeze. So I think it's really, really important to have an awareness, for everybody. And the reason I'm talking quite broadly is because actually I've got to run off and do a mental health seminar after this. So I'm going to say, Jackie, if there's any questions for me, can I throw it out there? Is that okay?
Absolutely. What I will do now, if that's okay, Christine, are you able to stay with us for, have you got 5 minutes?
Absolutely, yeah.
Right, can I invite the rest of the speakers to just kind of join us quickly? Basically, show your video and unmute your audio. But if anyone has any questions for Christina to start off with, perhaps we could kick that off while Dermot is preparing and collating some of the other questions. Does anybody have anything they would like to stick on the chat, or unmute yourself and ask Christina the question?
And apologies, I spoke so fast. That's me 100 miles per hour.
Great, Christina, that's great. At the moment, I don't have anything from you, but I suppose I could use the chair's prerogative to ask you, Christina. From your strategic kind of level of involvement, how much do you think there's an appetite for, digital consultations or remote consultations in the long term?
In the long term, I think we fast forwarded probably about 20 years. It takes 20 years to change anything, doesn't it, in the NHS? So, I know that there's people that have been asking, requesting clinicians included for many a year, and there's always a block. So I think, we always have to hunt for the positive. So the positive out of COVID is we've had a massive change of work, in the way that people work. So I think that, people talked about Zoom and fatigue and things like that, but that won't be how it would work going forward. So you would factor in, somebody mentioned breaks. So you would factor in breaks so that you're not at the screen. We're going to really heavy webinars. Even here, you've got 90 odd people. You wouldn't have a meeting normally around a table of 90 people. So it's that kind of we're working a very different way, and we're probably working much more hours in terms of like screen time than possibly we would ever do, and that's just generally. I think anybody who is working from home, you end up doing more because you're not factoring in the travel time, but you're still probably working.
Yeah, brilliant. And I suppose there's a question here from Damien. I hope I'm saying that right. With the current COVID situation in mind, i.e. 100% of new and follow-up done virtually, though I'm not so sure that that's true, how do you think this will affect the patient and clinician relationship?
Okay, so I'm aware that, within MSK services, not so much with pain, but within MSK services, there are still people having urgent kind of consultations. So it's very different across the country, unfortunately. It's one of the things I'm working towards. Quite thankful to be part of the MSK recovery strategy in terms of lived experience, which incorporates pain. So we are kind of hoping that lived experience is going to be a thread that goes much further. So there's quite a few on this call that are part of the expert group. Louise is one of them. So I don't think there's any going back to how it was. I think we need to work out what's best. And that's why the Change Challenge gives you an opportunity that if there is something that's really worked in your area, then please do enter it, because actually there'll be things that aren't that expensive that can be slightly changed. I think there is a lot of fear and it's uncomfortable. And I'm going off to a mental health discussion. So actually I've had therapy online. So I always thought that wouldn't work. So actually, why couldn't a pain psychologist do that online? Because actually some people aren't comfortable. So sometimes it may be that we have software people can just type. So I know that people will be saying about language differences, etc. Something like my mum, who English isn't her first language, there is no way she's going to be sitting there typing. So it's about that. It's that being sensible that this is like an add-on. This is like it's like a top-up to the services that have been amazing that we've already supplied. But actually, how can we access people who haven't been accessing services early enough? So by the time they've seen you, there is so much pain that actually you're at a point where they've been over-medicated, which sometimes happens by, people. It's unfortunate. I was like on lots and lots of tramadol and I managed to come off them. But actually, I'm aware I can't take gabapentin. But so that review that I had when I was at the pain management clinic, if somebody isn't having that review and they're just getting more and more meds, by the time they've come into you, it's quite difficult to undo some of that work, some of that kind of issues. So I think if you're getting people in earlier, then self-management can start earlier.
Right. Excellent. We do have a couple of more questions for you, but I wonder if Louise might be able to take some of those on if you are pressed for time, Christina.
What's the question? It depends how long it will take to answer.
All right, I'll give it to you. It's from, I think, Arthur, perhaps. So in this COVID environment, clinicians have had to respond very quickly under pressure. Training and support with digital consultations perhaps hasn't been there. How can we encourage managers to take a step back from too reactive mode to support clinicians to develop their digital skills?
Well, it's like everybody's done a crash course. So in the same way that clinicians have had to adapt, patients have had to adapt. And I think that's something that sometimes is forgotten amongst this, that actually everybody's had to adapt. And I think it should be a time of reflection. What's worked well, what hasn't, in terms of, national level, that is being looked at. So it is, what shouldn't be returned to, what hasn't worked. So we're having to look backwards a little bit, because obviously there has to be governance, and some things have just taken place that haven't gone through the usual governance, right? So, but if they're wonderful, great. If they're not, hell, we've got to stop them, right? So it's kind of, there is lots of work going on, and I'm sure that guidance will be coming out. But I think it depends on the trust. So I am in London. I'm very aware that within the state, as Camden MSK, within the borough, we have two, major hospitals, Royal Free and UCLH, so it's kind of very different. Whereas if you're rural, if I was a patient that had to travel 30 miles to go to a consultation that I could have, at home, then why not? It does, it actually, it could like free up some patient transport. It could be that people can't afford to travel 30 miles. So, at the moment, the economic kind of issue around the country may impact this as well. So people saying, oh, well, not everybody's got the phones. I'm very aware that there's homeless people that have got phones because I've, you know, had contact with them. So I think the reasoning behind not using technology is evaporating. I think it's not always the case. I think obviously everybody's different. Everybody has preferences. It's important to have choice. But, you know, I've got a 95-year-old lady on my patient advisory group, and she's been Zooming. So she was Zooming earlier with me. So I think we need to realise that the restrictions that we possibly had before aren't there now.
Brilliant. Thank you very much, Christina. Louise, I wonder if I could bring you in here. There's a number of questions there for you. So thinking about the first consultation, we've had some conversations about meeting your clinician in person first, and then going on to more remote consultations. What are your thoughts if your first consultation would have been via video, Louise?
Yeah, I mean, I think, again, it depends what you're faced with. Ideally, in an ideal world, I would say that it's preferable to have your very first consultation face-to-face. But, you know, with the situation with COVID, it's going to be a bit more difficult to do that. I think it also will depend on the complexity of the patient that you're seeing at the time. I mean, if you think you are going to need to see that person, then that should be your decision to make, I would have thought. But from my own personal point of view, I think, again, as I've said in the comments already, if the choice is to have a video consultation or a telephone consultation, whichever is your preferred method, or no consultation at all, then I would rather have one of the other, you know. So I think it all depends. But in an ideal world, yes, possibly the first consultation should be face-to-face, and then you can move to other methods moving forward. Does that help?
That does, I think. And I suppose with another follow-up from that is a more speculative question. What would you have done without any consultation or without any support?
I would have struggled, is the honest answer. Even with what I've learned since working as a volunteer in the pain field, I still struggled to implement, as I should think most people do, what I tell others to make it work for myself. So it was a case of trying to revisit all that I'd learned and make these things work for me again. So it was drawing on my own experience. But had I not had that experience, then I think I would have struggled quite a lot. So yeah, and I imagine there are going to be an awful lot of people with pain services having been suspended for so long that people are going to be struggling now. So yeah.
And I'm just keeping you on the screen because I can see you now, Louise, which is quite nice. A couple of things. One around frustration. Did you find anything about your virtual consultation frustrating? And were there any other barriers that you experienced that may not have happened if you had done this face-to-face?
No, I think I was lucky in that I am a person who is comfortable using this technology. So there weren't really any barriers. And in my case, the physio I spoke to didn't need to grab hold of my knee, if you like. So there weren't any issues around that. And language, of course, wasn't an issue. For me, there were no issues, but I imagine there could be one or two for some patients and clinicians. And probably the biggest barrier that people are going to experience is probably having the technology. So there will be some people, of course, as we know already, that can't or won't be able to access it. And we shouldn't forget those people. And I wonder if moving forward, there's going to be some way that individual trusts can maybe loan something to particular patients for the period of their treatment. I don't know.
Can I butt in? Sorry, Jackie, is that all right? I'm still here. I just say, it's not even so much about not having the IT, it's about we've got really poor networks. Everybody's working from home, so it's dropping out all the time and it's frustrating. So I can imagine if you're building up a rapport with a patient and it just freezes. it's frustrating, because I'll be honest with you, I've nearly thrown my work laptop across the wall. It's just like, oh, you know, like frustrating. But actually, if any of you are having, this is my IT tip, if any of you are having issues with your network, contact your provider and they can put you on a different frequency, as I learned this week. So yes. So, and for me, it's about not having, somebody said earlier on about more people wanting to use phone, and I think it might be to confidence. I think if I knew my consultant already, or consultant, or physio or psychologist, then maybe I'd be a bit more confident. But I would be nervous about them seeing my house, about I'm messy, especially people with chronic pain. I know that cleaning's gone out the window. It went out the window a long time ago, and I won't let a cleaner in now because of COVID. So it's that fear of like being judged. So I think it's just a very human kind of feeling. But I just wanted to say that I've also got myself involved in the Rehab Alliance, and trying to just encourage people to have more lived experience. So if you want to know how it's working for your patients, then reach out to some of them. You might be surprised.
Thank you, Christina. I'm noticing that the numbers are going down rapidly, and I'm aware of the time being 4 o'clock. So I just want to pause here and say thank you to everyone who has attended the webinar. I'm going to keep the panel here, and we're just going to go through the questions. Of course, if any members of the panel need to leave, that's fine. Just this way, there'll be something available on the recording, but if you do have to leave, we understand that. We want to let you know that the Physiotherapy Pain Association is here to support physiotherapists, and we have associate membership. So I would encourage you, if you wanted to, involve yourself with our work or the kind of resources that we're doing in the future, please consider joining us for membership. Details are on your screen and in the chat box, and it's only £20 a year for full membership and £10 for associate membership. So
and what about patients?
Yeah, that is also there in your associate membership. Okay. Absolutely.
Must go, guys. Thank you so much for having me.
Thank you, everyone.
But yeah, get in touch if you want to know more.
All right, brilliant. Then Leila, we have a couple of questions for you here around the safeguarding issues. I know that it's difficult to talk about the confidentiality side of things, but could you expand on what that might look like in a clinical consultation, this issue of safeguarding?
Yes, well, I've sort of partially responded to this in the chat, but if we see someone in a clinical consultation and we think it might be useful to speak to them individually, we can usually find a way of doing that by asking them to go somewhere else in the building. And we also have teams that sometimes we can meet with the patient as well. So obviously we can't do that on virtual consultations.
Thank you, Leila. Does anybody else have any experience of this issue around safeguarding, security, confidentiality?
We did have ways of working with it, but again, for the purposes of safeguarding, I don't think it's a good idea to talk about in this forum.
Yeah, absolutely. Anyone else have anything to interject there?
It's not directly related to safeguarding, but there is something about the space and the environment of the office or whether you're at home. So things like setting up individual consultation rooms rather than being in an office with other people around, because we don't know when a patient's going to share some information that is a little bit more sensitive. So I think the environment plays a huge part in this as well.
Thank you. And do we still have Anthony on here? Is he still with us?
Yes, I'm here.
Excellent. You've got lots of questions. That was a really engaging presentation, and being able to see what it's like on the floor and evaluating at pace. So there's this issue around cost cutting, which I think is a good question for you, is if this becomes the new normal, for want of a better word, this issue of cost cutting, might it lead to a move away from face-to-face?
Yeah, I mean, it's a real concern, actually. I've been researching this space for a few years now, and we did an acceptability study back in 2015, and we tried to move forwards with virtual consultations, but essentially the way that services are commissioned, if you have a face-to-face consultation in any format, you're paid a certain amount. If it's a non-face-to-face consultation, they tend to be commissioned at, say, a telephone rate. So for us as a specialist tertiary centre who delivers, you know, excellent care and all the rest of it, but it's very complex stuff, and delivering things virtually, which might make it more accessible and easier for patients to attend, particularly we see patients coming down from or across from Wales or from Scotland or from all around the country. It would make sense for those who would prefer to have a virtual consultation for them to have that. But when it came down to it from a commissioning point of view, we just can't afford. It disincentivises providers to offer virtual consultations when you're only being paid, or the trust is only being paid 20% of the overall income. And I think at the time when budgets are being cut and you're having to make cost improvement savings, it's not a viable option. So there has been some work done nationally around commissioning of services, and there are, my understanding, and I'm not an expert in this at all, but I could find out some more information if required. But I think there are some services locally that are commissioned now to give virtual consultations that don't necessarily cost less. But as we've said, I mean, we're finding that potentially, although I believe that we're still paid the same amount and everything is being done virtually, but if all of a sudden it changes to being 50% of the rate you would do, that is financially going to disincentivise people from using virtual consultations. There's a lot of work that needs to be done, and I think at a policy level, there needs to be some really careful thinking about how we move forward beyond COVID, because it could potentially financially, you know, really affect the way services are run.
Yeah, and could you speak to this idea of it not being legally possible to make a diagnosis virtually, because obviously your trust has taken this on board with full support strategically. Has this come up for you at all?
Yeah, so I mean, it came from Damien, and then we've exchanged messages privately, and I'm going to look into it from I'm going to pass it on to the CSP, because I think that's I'm not 100% sure on that. I think it's a really important point. Now, from my organisation standpoint, I'm not speaking on behalf of the organisation. This is me, you know, my own views. But from experience, if a clinician believes that a patient needs to come in, then they will come into the hospital, and there are the COVID precautions that are being made. But I think as our hospital moves towards what's called a green site, so we're trying to be a COVID-free site. There's a lot of work, which I'm not 100% sure what exactly is happening to the detail. There's a lot of work going on around this. So, but a lot of our, you know, within some of the surgical specialities, diagnosis isn't necessarily just made on hands-on assessment. There's imaging, there's blood, there's all sorts of things as well. So I think the argument some of our clinicians would make is that you don't necessarily need to have a one-to-one face-to-face appointment in order to make a diagnosis. But the caveat I would say is that we are a tertiary centre, and often our patients have already been thoroughly investigated anyway. So it's very different to a primary care setting where maybe somebody hasn't been seen before. And obviously if a clinician is screening a patient and there are any causes for concern, then they would be, you know, I suspect they'll be brought in for a face-to-face examination, sort of as you would do normally.
Right, brilliant. Thank you. We've got a couple of questions that I think have been answered in the chat around how to do interpreter questions. There's this issue around staff confidence and competence. So I suppose I can finish off by asking all our panel to speak about this feel of staff confidence and competence, because Christina has told us quite clearly that, you know, that is something that patients are experiencing as well. So maybe final comments on this idea of staff confidence and competence in providing digital consultations. If you're happy to go first there, Anthony.
So I suppose my observations over the last few months, I mean, we started doing this properly in March, nearly 3 months into it. I think staff members have become a lot more confident the more they've used it. And I mentioned in my talk that we had a large number of colleagues who were there as floor walkers. So if ever a clinician had any difficulty, and I was based around, within therapy, so helping mainly my physio colleagues, but if they had any troubleshooting issues, I was there to sort of help them out. And I think the first time anything happens, well, it's all very unknown, isn't it? And I think there's the anxieties of the unknown that maybe puts people off. But the more people have used it, the more competent and confident they have become. So I think it's a real testament to how clinicians have responded to this. And I suppose it is very difficult for us as clinicians. I mean, you have your appointment time, and then a patient's there in the waiting area, and you turn up, and then you meet them, and you greet them, and you walk them down, and it's very much our physiotherapy arena, isn't it? We've got access to all of the stuff we need, the kit we need, we know where everything is. But then for a clinician who maybe isn't familiar with using technology, I mean, I know some clinicians who can barely click a mouse, to be honest, and then to have to deliver, a high level complex interaction over a screen, it's really unnerving. So I think clinicians who are feeling like that need support, but I would say that people do get a lot better and more confident the more they go on. And that wasn't a brief answer, I'm sorry.
That's great. Thank you very much, Anthony. Selena, I'll come to you next.
I would echo what Anthony said, really. I think from our teams, I think the more people have had practice with it, the more familiar we've got with it. And those smaller team meetings, even the WhatsApp groups of, oh, this happened to me today, I was showing an exercise and the dog jumped on my back. Those sort of highs and lows of what happened are quite reassuring. And I think what I've really been struck by when I've either telephoned or videoed a patient is the common ground we've all got is we're dealing with a lot of uncertainty, and people are up and down at the moment, all of us, clinicians, patients, and that gives us an instant alliance. So that rapport that we're worried about that we may not be able to make, I think we make quite quickly in this situation, because we're dealing with a strange time, and people are appreciative of anything we can do to field that.
Emma, over to you.
I'm not sure I've got a huge amount more to add than what's already been said. I think just as time is going on, people try things out and they have developed confidence with it. But I suppose also as more clinicians are using it, there's that more peer support, as others have mentioned, that I think encourages others to see, well, if they can do it, we can all try it out and support each other in it. I guess that's all I would add.
Thank you. Claire?
I would agree with that, and I think as all our clinicians have been really kind of brave and willing to try something new, and there have been anxieties, and I agree that the more we started, a lot of the anxieties were how the technology was going to work, and then once you actually were face to face with a patient, there was almost a breath of relief that, okay, now you go back into what you know. The other thing I think is that sense of connection. So if you've had team members who have been working at home versus the ones who haven't had any interactions with other colleagues directly, that can be very, very anxiety provoking. So it's kind of balancing all of that as well with the new technology, the sense of connection, the anxiety of living amongst a pandemic. But I think I agree with this, Selena, with the meetings and the WhatsApps and the check-ins has been a huge part of that, and not overloading people with too many emails as well.
Perfect. And Leila, I know you've already said something, but was there anything you wanted to add to that?
Not particularly. I did notice one of the other questions was about, do we have any ideas about numbers, or when we might see, or whether we're going to get an increase in referrals? I don't have any ideas about numbers, but I do think there is some evidence around the 2008 financial recession that did result in an increase in numbers of patients accessing mental health and pain services. So it may be that later down the line, that's what will happen.
All right. I think there is a paper I will try and share in the chat if I remember how to do it, but that a paper's been published by Eve Corner. She's an ICU physiotherapist and has referenced the increase in chronic pain that they're anticipating in that particular population. So with that random fact, I'm going to thank all our panel speakers and everyone who's come to engage with us in this time. Hopefully see you at any of our other events, and I can wind this up now and say thank you.